Acute exacerbations of COPD constitute a major burden both to patients and to healthcare systems. They constitute 1 in 8 emergency admissions to hospital. Readmissions are common at rates up to 20% within 28 days. In-hospital mortality can be as high as 10%, and patients may present with acidosis in about a fifth of cases. Even when patients do come into hospital and start to recover, a significant proportion may deteriorate following hospital admission. The questions then are, how can we detect when patients are getting worse whilst they're in hospital? And how can we detect when patients are now, how can we determine whether patients are safe for discharge? What we therefore need is a physiological biomarker to identify disease progression and severity, response to treatment, and the early identification of treatment failure. A myriad of biomarkers have been proposed in the past, both molecular and cellular, but all the inflammatory processes and the pathophysiological processes that occur in the lung during an exacerbation finally end with increased breathlessness. So if we can find a physiological biomarker that can quantify the degree of breathlessness the patient experiences, then we may be able to identify those patients whose symptoms are deteriorating despite treatment. We propose neural respiratory drive as such a biomarker. Neural respiratory drive constitutes the balance between the load on the respiratory system and the capacity of the respiratory muscle pump. During an exacerbation of COPD, patients experience increases in resistive, elastic, threshold, and metabolic loads. Similarly, they experience reduction in the capacity of their respiratory muscle pump. As they become hyperinflated, functional diaphragm weakness develops, and thus reducing the functional capacity of the respiratory muscle pump. And those two factors, an increase in the load on the respiratory muscle pump and a reduction in its capacity, leads to an increase in the neural respiratory drive, and that manifests as increasing breathlessness in the clinical context. So how do we measure neural respiratory drive? Well, the gold standard method of measuring neural respiratory drive in humans is through diaphragm electromyography. And it's well validated in COPD, but because it involves the insertion of an esophageal catheter, it is invasive and therefore poorly tolerated in acutely unwell patients. So is there a non-invasive alternative? Well, we propose second intercostal space parasternal intercostal muscle electromyography as such an alternative. The second intercostal space parasternal muscles are obligate muscles of inspiration that are readily amenable to surface EMG, and parasternal EMG has been validated as a useful tool to quantify neural respiratory drive in patients with asthma, cystic fibrosis, pulmonary fibrosis, and COPD. It's quite easy to acquire. We seat patients at 45 degrees, apply wet gel electrodes to their second intercostal spaces, perform a sniff maneuver, that's a maximal maneuver against which to normalize the tidal breathing inspiratory parasternal EMG, and then we record the EMG for 10 minutes. It's well tolerated by most patients, and we have found that in pilot data, the change in parasternal EMG between admission and discharge can distinguish between those patients who require readmission within 14 days and those who do not. Similarly, changes in parasternal EMG can distinguish between patients who have deteriorated according to physician opinion and those who have improved. But those pilot data were obtained in a relatively small cohort of patients, and therefore we proposed a larger cohort study to confirm these findings. We had 3 hypotheses in mind. Firstly, do changes in parasternal EMG as a measure of neural respiratory drive between admission and discharge predict readmission at 14 and 28 days following hospitalization with COPD exacerbation? The second hypothesis was whether parasternal EMG may detect clinical deterioration as defined by increasing breathlessness or by physician-defined deterioration. And finally, we wanted to discern whether the changes in parasternal EMG between admission and discharge correlated with changes in physiological load as measured by inspiratory capacity and spirometry. We recruited 120 patients within 12 hours of admission to the emergency department of a London teaching hospital, and we performed parasternal EMG on a daily basis between admission and discharge. We also performed inspiratory capacity manoeuvres, spirometry, recording of medical early warning scores, and routine physiological variables. And the results showed that there was, we demonstrated that in this cohort of 120 patients, that only age and admission frequency predicted 28-day readmission in the whole group of patients. However, in a post-hoc analysis of patients under the age of 85, we found that age and changes in parasternal EMG between admission and discharge predicted 28-day readmission. Furthermore, we found that only parasternal EMG predicted 14-day readmission. If we chose a cutoff value of a fall in parasternal EMG of 3.1 units between admission and discharge, we found that this had a negative predicted value of 97.7% in detecting 14-day readmission. What about our second hypothesis? That is whether parasternal EMG changes can detect clinical deterioration. Well, we found that parasternal EMG changes between consecutive measurements detected symptomatic deterioration as defined by at least a 1-point increase in the Borg score. Furthermore, we found that parasternal EMG changes between consecutive recordings detected physician-defined clinical deterioration. Finally, we found that changes in parasternal EMG between admission and discharge were weakly but significantly correlated with changes in both inspiratory capacity and FEV1, indicating that the parasternal EMG reflects the changes in the physiological loads imposed on the respiratory system. So in conclusion, we find that neural respiratory drive, as measured by parasternal EMG, predicts readmission at 28 days in patients under the age of 85. It also predicts readmission in all patients within 14 days. It detects clinical deterioration as defined by symptoms and also by physician opinion. And we also found that it was physiologically coherent in that changes in parasternal EMG reflected changes in both FEV1 and inspiratory capacity.